video we're going to look at airway, assessing an airway to see if it is patent, opening an airway with manual maneuvers, head tilt chin lift, or jaw thrust, and then open the airway with nasal pharyngeal airway or oral pharyngeal airway. So two manual ways of opening the airway, first being the head tilt chin jaw lift, just downward pressure on the top of the forehead and upward pulling the mandible up, so we rotate the head up like this. What this does is as we pull the jaw up, we're opening the mouth and also getting that tongue off the posterior aspect of the throat, pulling it up, so we open that up. So this is a maneuver obviously not for a patient that we're concerned about any kind of spinal injuries with head or neck trauma. For that patient, we don't want to be manipulating their head around. That patient, we're going to be using the jaw thrust. Best way to do a jaw thrust is make two wee paddles with your index fingers, put your thumbs on the cheekbone, and flip their jaw up. So you're scooping that jaw up off their face. And think of that jaw being attached to the tongue. You're pulling that tongue off the posterior aspect of the pharynx. So after we open that airway with a jaw thrust or head tilt chin lift and open up the airway, if we were to see any secretions at that back of the throat, we're going to suction using our automatic suction ideally with a rigid tip, a yanker tip on the end of this. Now, a couple of things to remember when you're suctioning. We like to suction what we can see. We'd like not to be jamming down past where we can't see. Just suction the posterior pharynx. Some references would suggest that you measure this the same as an OPA, but if you can see where you're at, you're not in any trouble. As far as suction, when you turn your suction on, it's either on, generally, or off, is what you'll find out in practice. There's a wee gauge here on the side, and for adults we would like not to go over 120 millimeters of pressure, and for pediatrics half of that, 80 millimeters of mercury of pressure negative. And how you would accomplish that pressure isn't by turning it up to the highest level. It would be by jamming it against some tissue and letting it build up pressure. We could cause damage to tissue there. So we would just insert, turn the machine on, insert, suction the posterior pharynx, and come out once we have all the secretions in. Next, the most common adjunct that we would use for opening a patient's airway is an oropharyngeal airway. It's just a large tube that's going to go from their mouth down to the larynx. It's just a fairly large bore tube. And the main purpose of that tube is getting rid of that tongue from the posterior aspect of the throat, closing off the airway in the back of the airway. And when we open that airway up by pulling the tongue forward, so splinting it up. OPA is just a stopgap to get towards intubation for an ALS provider. But it's a very useful tool when going to bag valve mask that patient, or just keeping that airway open for that patient to breathe themselves. So any patient that can tolerate it can take it. Good correlation, if you touch their eyelashes and they blink, they probably have enough of an intact gag reflex that they're not going to like this, shoving this in the back of your throat. And some patients, after we check that, we're just going to gently insert. If we were ever to get any gagging, then we would withdraw and use NPAs on that patient. How we insert it, two ways for an adult. My preferred method would be to insert and then rotate. So we're going to insert along the top of along the hard palate. And once we hit, so we're just getting around the tongue, once we hit any resistance, we're just going to flip it around 180 degrees and advance the rest of the way. And all that does is allow us to scoop away from their tongue and get around their tongue. The other way would be to use a tongue depressor, or maybe you just open the airway and their tongue's not that big and you can just slide the oropharyngeal airway over the top. If not, you would use a tongue depressor, hold the tongue and insert in. Often we're not going to look for popsicle sticks to insert an OPA. In children, we would not insert an OPA against the hard or soft palate. It's not fully developed, and we can end up causing tissue damage there. So next we have the nasopharyngeal airway, which is a small tube, can be inserted into either nostril, which goes down to the base of the tongue, just at the level of the epiglottis, where the larynx is, where the beginning of our trachea is. Not highly utilized pre-hospitally for some reason. We should use these. These are really good tools, and anyone who's not maintaining their airway, talking to you, and in fact minding this going into their nose should have it. It would be after we would use our OPA, because that would be a larger bore and more easy to put in and less problems like bleeding. But when these are inserted properly, we can avert most of those problems. So first, we're going to measure from the nostril to the corner, to the condyles of the mandible, or the corner of the jaw. After we've measured, this is the appropriate side. We're going to pick the largest nostril that you see. Some references will tell you there's one larger than the other, but just look and see which is larger. When we're inserting, we're going to apply a liberal amount of mucal water-based lubrication. When we're inserting, we're not inserting up towards, we're not picking their nose with it. What we're doing is we're going to follow that hard and soft palate, if we can picture it straight back, as if we're nailing that patient's head to the bed rather than going up. One area is that we'd like to stay away. We take this tip, this is called the bevel. We'd not like to, it's not very likely, but if a patient was prone to nosebleeds, there's an area right on your, in the inside of your septum, midline, that's called Little's area. Lots of vasculature there. Often that's where big nosebleeds are. So we'd like not to cause a large nosebleed in this patient. So liberal lubrication, and to take that tip or that bevel away from the septum, and as we advance down. So we're going to advance down. If we were to hit any resistance, we would not push past any resistance. We'd withdraw and try in the other nostril. You could also try rotating a little bit as we go in, not pushing against any resistance. And if you advance this straight down, straight back towards the bed rather than towards the top of their head, you'll have no problem in advancing this in most patients. Another tweed jacket production.